Good morning, students. Today's topic is hemoglobin competition number 6.11. The last topic is various types of jaundice. Hyperbilirubinemia or jaundice, these two words are mutually used. Based on causes, the hyperbilirubinemia is of two types, congenital and acquired. Also, depending upon the nature of bilirubin elevated in the condition, hyperbilirubinemia is also grouped into conjugated hyperbilirubinemia, unconjugated hyperbilirubinemia, and a condition where both type of bilirubin increases. Out of these, congenital and acquired types of hyperbilirubinemia or jaundice are important. Now, what is jaundice? Jaundice is nothing but yellowish discoloration of skin and mucous membrane. There are three types of jaundice: prehepatic jaundice or hemolytic jaundice, hepatic jaundice, and third is posthepatic jaundice or obstructive jaundice. First, we will study about congenital hyperbilirubinemias. They result from abnormal uptake, conjugation and excretion of bilirubin due to inherited defects. In the last lecture, I have told you three mechanisms for excretion of bilirubin. First, liver cell will take the unconjugated bilirubin from the blood. In the liver cell, this unconjugated bilirubin is conjugated, and after conjugation, the conjugated bilirubin is excreted into the bile by the liver cells. So, depending upon this, there are four types of congenital hyperbilirubinemias. First is Crigler-Najjar syndrome, Gilbert disease, Dubin-Johnson syndrome, and Rotor syndrome. First, Crigler-Najjar syndrome. Here, defect is in conjugation of bilirubin. There are two types. In type 1, Crigler-Najjar syndrome, which is also called as congenital non-hemolytic jaundice, there is severe deficiency of enzyme UDP glucuronyl transferase. What is the role of this enzyme? This enzyme helps in the conjugation of unconjugated bilirubin to conjugated bilirubin with the help of glucuronic acid. So this is the step that we have studied in the last lecture. So UDP glucuronyl transferase convert the unconjugated bilirubin into conjugated bilirubin, and after conjugation, bilirubin can be easily excreted because it becomes water soluble. So in this case, due to deficiency of enzyme UDP glucuronyl transferase, conjugation process is affected, and hence unconjugated bilirubin level increases. The disease is often fatal and children die before the age of 2 years. Here, jaundice appears within 24 hours of life. This point is important because in physiological jaundice appears on second day. Here, jaundice appears within 24 hours. As I have told you, unconjugated bilirubin increases. If it increases more than 20 mg per deciliter in the blood, then it crosses the blood-brain barrier of baby because that blood-brain barrier is immature, and this unconjugated bilirubin is lipophilic. Therefore, it easily diffuses into the brain tissues, leading to a dreadful condition called as kernicterus. Type 2 Crigler-Najjar syndrome is milder form. Here, enzyme deficiency is not that much severe. Only second stage of conjugation is affected. That is also improved by giving a drug phenobarbital, which improves the conjugation process. And in this case, bilirubin level does not exceed 20 mg per deciliter. Gilbert's disease, it is inherited autosomal dominant trait. In this case, the defect is in the uptake of bilirubin by liver. Therefore, unconjugated bilirubin remains in the blood and its level in the blood increases, but bilirubin level is usually around 3 mg per deciliter. Here there is defect in the uptake, but complete defect is not there. Therefore, bilirubin level is not increased very much. The patient is usually asymptomatic except for the presence of mild jaundice. So this is the process. Liver will take the bilirubin from blood, conjugate inside the liver cell, and after conjugation the liver will excrete the conjugated bilirubin into the small intestine. From small intestine it goes to the large intestine. In the large intestine, bacterial flora acts on that conjugated bilirubin and convert that bilirubin into urobilinogen and stercobilinogen. So these two bilinogens are formed in the large intestine from conjugated bilirubin. Next type of congenital jaundice is Dubin-Johnson syndrome. It is autosomal recessive trait. There is defective excretion of conjugated bilirubin in the biliary canaliculi. Here uptake and conjugation process are normal, but there is defect in the excretion of bilirubin. Therefore, the conjugated bilirubin regurgitate back into the blood and its level in the blood increases. This disease is due to defect in the ATP dependent organic anion transport in biliary canaliculi. Here bilirubin get deposited on the surface of liver and liver appears black. Therefore, it is also referred to as black liver jaundice. Last is Rotor syndrome. It is autosomal recessive condition. It is similar to Dubin-Johnson syndrome. Bilirubin excretion is defective in this case, but there is no staining of liver. So this is the summary of congenital hyperbilirubinemias. In Crigler-Najjar syndrome and Gilbert disease, unconjugated bilirubin is increased. Gilbert disease is a mild disease, whereas Crigler-Najjar syndrome is a fatal disease, particularly type 1. In Dubin-Johnson syndrome and Rotor syndrome, conjugated bilirubin increases. Now this is a clinical case. Newly born baby develop yellowish discoloration of skin and mucous membrane. Laboratory investigation shows unconjugated bilirubin level is 15 mg per deciliter. Probable diagnosis, biochemical defect and complications. Probable diagnosis is Crigler-Najjar syndrome. Biochemical defect is there is deficiency of UDP glucuronyl transferase enzyme. Therefore, there is defective conjugation of unconjugated bilirubin and its excretion is hampered. Therefore, unconjugated bilirubin level increases. The complications are if this bilirubin increases above 20 mg per deciliter, it gets deposited in the brain, leading to a fatal condition called as kernicterus. After completing congenital types of hyperbilirubinemia, we will come to acquired types. So there are 5 types of acquired hyperbilirubinemias: physiological jaundice, breast milk jaundice, hemolytic jaundice, hepatocellular jaundice and obstructive jaundice. First is physiological jaundice. It is also called as neonatal hyperbilirubinemia. It occurs in or it is seen in all newborn infants. After second day of life, mild jaundice appears. Why this jaundice appears or why there is hyperbilirubinemia? This is due to 2 facts. First is accelerated rate of destruction of RBCs after birth. In the fetus, the RBC count is high as compared to our body. Therefore, after birth, the excess amount of RBCs get destroyed rapidly. All of us know when the RBCs are destroyed, heme is released and bilirubin level is high. At the same time, the liver of that infant or baby is immature to handle the excess load of unconjugated bilirubin. Because of these 2 reasons, there is physiological jaundice. Now in such cases, bilirubin does not increases above 5 mg per deciliter and this physiological jaundice disappears by second week of life. Breast milk jaundice means it is nothing but it is seen in breastfed infants. It is prolongation of physiological jaundice. Just now I have told you physiological jaundice lasts for 2 weeks, but if this physiological jaundice lasts for more than 2 weeks, it is called as breast milk jaundice. This is because high levels of estrogen derivatives are seen in maternal blood after birth of a baby. These estrogen derivatives are excreted into the milk, and from the milk they enter into the fetal circulation, fetal body or fetal circulation. In the fetal body, when these estrogen derivatives reach, they inhibit the enzyme glucuronil transferase in the fetus. Therefore, the process of conjugation of bilirubin hampers, and so the excretion of bilirubin occurs at slower rate. Second reason is if mother is taking some drugs like sulfa drugs, these drugs get also excreted into the mother's milk. Through the milk they enter into the fetal body, and when they enter into the fetal body, they displace the unconjugated bilirubin from albumin. Now in the last lecture I have told you, when unconjugated bilirubin is transported from spleen to liver, it binds with albumin. So albumin is a transporter here. When these drugs enter into the fetal circulation, they also binds with albumin and they displace the bilirubin from albumin. Hence, conjugated bilirubin is not transported to liver for excretion and its level in the body increases. So these are because of these two reasons, there is extension of physiological jaundice is seen in breastfed infants, and hence the name breast milk jaundice. A clinical case is there on this topic. A newborn baby developed yellowish discoloration of skin and mucous membrane. Previously it was considered as physiological jaundice, but its period extends beyond 2 weeks. Laboratory investigation show increase in unconjugated bilirubin level up to 3 mg per deciliter. The most probable cause of this extension is, just now I have told you, 2 reasons. Most probable diagnosis is physiological jaundice, also called as breast milk jaundice. The cause of extension of period is intake of sulfa drugs or high levels of estrogen in the maternal circulation. Just now I have explained. Now come to acquired hyperbilirubinemias. First is hemolytic jaundice of newborn. The most common cause of this is Rh incompatibility. Here mother is Rh negative and fetus is Rh positive. That means mother does not have Rh antigen, fetus have Rh antigen. When fetal blood enters into the maternal circulation during childbirth, Rh antigen from fetus also enter into the maternal circulation and mother produces antibodies against this Rh antigen. Now these antibodies enter into the fetal circulation and damage the RBCs of fetus, leading to a condition called as erythroblastosis fetalis. Now we will study this in more details. Erythroblastosis fetalis, as I have told you, it is Rh incompatibility. The first child often escape because antibodies are not present in maternal circulation during first pregnancy. During the first childbirth, fetal blood enters into the maternal circulation, so the Rh antigen from fetus enter into the maternal circulation and the mother body forms antibodies against this Rh antigen. In the second pregnancy, these Rh antibodies, which are IgG type, will crosses the placenta and enter into the fetal circulation. These antibodies attack the Rh antigen present in the fetus and destroy the fetal red blood cell even before birth. Sometimes the child born with severe hemolytic disease, often referred to as erythroblastosis fetalis. In this case, the bilirubin level may increases to more than 20 milligram per deciliter, and mostly it is unconjugated bilirubin. In newborn, just I have told you, blood-brain barrier is not fully matured, therefore unconjugated bilirubin or free bilirubin crosses the blood-brain barrier and get deposited into the brain, leading to a condition called as kernicterus. In this kernicterus, the patient may suffer from mental retardation, fits, toxic encephalitis, spasticity, or sometimes death may occur. How will you manage this? Management is exchange transfusion. Means fetal blood is taken out and fresh blood transfusion is given to the patient. Along with that, phototherapy is given. In phototherapy, the fetus, the baby is exposed to a blue light of 440 nanometer wavelength. This light, when enters into the fetal body, acts on conjugated bilirubin present in the blood and convert that unconjugated bilirubin into its isomer, and that isomer is soluble in water. Unconjugated bilirubin is insoluble in water, but after phototherapy the unconjugated bilirubin becomes soluble and it get easily excreted through the urine without conjugation. So there are some conditions. Mother with B negative and fetus is B positive. Effect on first child. There is no effect on first child. What is the reason? Because B positive means Rh antigen is present, and this Rh antigen is present in fetus. There is no transfer of antigen and antibody from fetus to mother. Only antibodies are transferred from mother to fetus. So in this case, in mother is B negative, so no antibodies are present in her circulation and there is no effect on first child. Second is, mother is B negative and fetus is again B positive. What is the effect on second child? Here, during the delivery of first child, small amount of blood in the process of labor of fetus enter into the maternal circulation, and along with that blood, Rh antigen also enters into the maternal circulation. Now when this Rh antigen enter into the maternal circulation, it is new for her, so that maternal blood synthesizes antibodies against that Rh antigen, and these antibodies will remain in the maternal circulation. When the second baby is again Rh positive, then the antibodies which are already formed against Rh antigen in the maternal circulation enter into the fetal circulation and destroy the fetal RBCs, leading to erythroblastosis fetalis. Next condition is when mother is B positive and fetus is A positive. What is the effect on child? When mother is B positive, that means she may have anti-A antibodies, and anti-A antibodies will act on A antigen of the fetus, but this is not seen because ABO blood grouping, here the antibodies are of IgM type, and these IgM antibodies does not crosses the placenta. Therefore, though antibodies are present in the maternal circulation against A antigen of fetus, they does not process the placenta to destroy the fetus RBCs. So there is no effect in the third case. Now come to the hemolytic jaundice of adult. The condition is characterized by increase in unconjugated bilirubin in the blood. Again, hemolysis occurs. Hemolysis means increased rate of breakdown of RBCs. increase formation of heme, increase formation of bilirubin. Bilirubin is unconjugated, so unconjugated bilirubin level increases. There is absence of bilirubinemia, bilirubinuria. That means presence of bilirubin in urine is absent, or bilirubin is absent in urine, in short. Why? Because unconjugated bilirubin level is increased in the blood. Unconjugated bilirubin is insoluble in water, therefore it is not excreted through the urine, and hence bilirubin is absent in the urine. But there is excessive excretion of urobilinogen in urine and stercobilinogen in feces. Why this is so? Because if you see, it is a adult liver. When unconjugated bilirubin level is increased due to hemolysis, the adult liver try to conjugate more and more bilirubin and try to excrete that bilirubin through the bile. So the concentration of conjugated bilirubin in the bile increases, but concentration of conjugated bilirubin in the blood does not increases, right? Unconjugated bilirubin increases, so liver will take that more and more unconjugated bilirubin, conjugate it and excrete through the bile. So in the bile, conjugated bilirubin level increases. This conjugated bilirubin level through the bile goes to the small intestine, large intestine. In the large intestine, this conjugated bilirubin is converted into urobilinogen and stercobilinogen. As more and more conjugated bilirubin is reaching to the large intestine, more and more urobilinogen and stercobilinogen is formed in this case. Hence, there is excessive excretion of urobilinogen in urine and stercobilinogen in feces. This urobilinogen in urine is detected by Ehrlich test. So Ehrlich test is very important for the diagnosis of hemolytic jaundice. Now the common causes of hemolytic jaundice are spherocytosis. Spherocytosis means spherical shape of RBCs. Normally the normal shape of RBC is biconcave, but when this shape changes and it becomes spherical, and such RBCs when tries to travel through the capillaries, blood capillaries, they get damaged and hemolysis occurs. Second cause is glucose 6-phosphate dehydrogenase deficiency. Now this enzyme is essential for the formation of NADPH, and this NADPH is essential to maintain the RBC membrane integrity. When this enzyme is absent, NADPH level in the body decreases, and hence RBC membrane are not maintained. They get easily damaged, leading to hemolysis. Autoimmune hemolytic anemias. Autoimmune means antibodies against own antigen. Here antibodies are synthesized against the antigens present on RBCs. These antibodies attack the RBC and destroy the RBCs. Toxins like carbon tetrachloride also break down the RBC membrane, leading to hemolysis. Next cause is malaria. Malaria, all of us know, malarial parasite multiplies inside the RBCs, and after multiplication it breaks that RBC and comes out, leading to hemolysis. Mismatched blood transfusion. Due to antigen antibody reaction, there is hemolysis of RBCs are seen. You can also add sickle cell disease in this list. This is a clinical case. A patient was suffering from malaria from 1 month. The questions are: comment the level of bilirubin and type of jaundice. Name the test done for estimation of bilirubin. Name the other condition in which this type of bilirubin increases. So these are answers. Unconjugated bilirubin level increases due to hemolysis. So it is called as hemolytic or prehepatic jaundice. Test for estimation of bilirubin is indirect Vandenberg test. The other condition in which unconjugated bilirubin increases are congenital spherocytosis, G6PD deficiency, autoimmune hemolytic anemias, toxins, mismatched blood transfusion, or sickle cell disease. Next is hepatocellular jaundice. Here it may be seen in two ways. when it is pure hepatocellular disease, means in the initial stages when the liver cells are damaged, conjugation process is hampered. So conjugation in liver is decreased and hence unconjugated bilirubin is increased in the circulation. But during the course of the disease, there is inflammation of the liver cells. Due to this edema or inflammation of liver cells, they compress the intracellular canaliculi which drains the bile from liver to biliary tree. Therefore, there is intrahepatic obstruction. When there is intrahepatic obstruction, the bile which is present in the canaliculi inside the liver is conjugated type. This conjugated type of bilirubin, due to obstruction, does not go to the biliary tree. It gets regurgitated back into the blood. Therefore, conjugated bilirubin level also increases. So here mixed type of jaundice is seen. Unconjugated bilirubin is also increased because of lack of conjugation in liver cell, and conjugated bilirubin also increases because of intrahepatic obstruction. Bilirubinuria is also seen, means presence of bilirubin in urine, which is detected by Fauchett's test. Here urobilinogen levels in the urine may be normal or decrease. Why urobilinogen is decreased? Again, you have to see this diagram. Urobilinogens are formed in large intestine. Whenever there is obstruction to the bile flow, the conjugated bilirubin does not reach the large intestine, or less amount of conjugated bilirubin reaches the large intestine, leading to less formation of urobilinogen. So urobilinogen level is decreased or normal, but in hemolytic jaundice urobilinogen level is increased, which is detected by early test. The most common causes of hepatic damages are hepatitis A, B, C, D, E. These are the different types of viruses which causes damage to the liver. Next causes are bacterial infection and parasitic infestations, cirrhosis of liver due to alcoholism or poisons, cancers of liver also called as hepatoma, and causes of intrahepatic obstruction or intrahepatic cholestasis are all the above cases. When they becomes obstructive, or when the liver cell get inflamed, they causes intrahepatic obstructions. Now about hepatitis A and hepatitis B. Hepatitis A is most common. It's spread by contaminated water and food. It is a mild disease, lasts for few days and required no treatment. Whereas hepatitis B is most dreadful disease, spread by blood and body secretions. It is incurable, lasts throughout life, no treatment is available. Vaccine is available, but it should be taken before infection. Clinical case on this topic: 45-year-old patient admitted in hospital with yellowish discoloration of skin and mucous membrane. On history, it was found that patient had such episodes in the past since last 5 years. On laboratory investigation, his total bilirubin level is 3.4, and conjugated bilirubin is 2.1, conjugated bilirubin is 1.4. SGPT, serum SGPT is 85 international unit per liter, and HBsAg, which is also called as Austrial antigen test, is positive. Questions are: diagnosis, what is your diagnosis, type of jaundice, biochemical basis of rise in bilirubin, urinary findings, other causes of disease, and role of vaccine. And these are the answers. Your diagnosis is chronic active hepatitis leading to hepatic jaundice. Biochemical basis of rise in bilirubin: unconjugated bilirubin increases due to decrease in liver function of conjugation, and conjugated bilirubin level increases due to intrahepatic obstruction. Urinary findings: excretion of bilirubin in urine detected by Fauchett's test. Causes of above case, again same cases: hepatitis A, B, C, D, E, parasitic infestation, cirrhosis of liver due to alcohol and poison, cancer of liver called hepatoma. What is the role of vaccine in above case? No role of vaccine as patient is already infected. Vaccine has role only before infection. Next type of jaundice is obstructive jaundice. In this obstructive jaundice, conjugated bilirubin level is increased. Conjugation of bilirubin in the liver occurs normally, but due to obstruction, this conjugated bilirubin does not excrete into the bile. Therefore, conjugated bilirubin regurgitated back into the blood and its level in the blood increases. There are two types of obstruction: intrahepatic obstruction, extrahepatic obstruction. Causes of intrahepatic obstructions are biliary cirrhosis and lymphomas. When there is inflammation of lymph nodes surrounding the liver, these lymph nodes press on the liver, leading to its compression and obstruction to the bile flow. Extrahepatic causes of obstruction are stones in the gallbladder or biliary tree, carcinoma of head of pancreas, stricture of biliary tree, and enlarged lymph nodes in the porta hepatis. Here, conjugated bilirubin is increased in the blood and its excretion in the urine, leading to bilirubinemia, which is detected by Fauchett's test. If there is total obstruction to the biliary tree, the bile does not reaches the intestine because of obstruction. Therefore, no pigments, that means no bilirubin, enter into the blood, and there is no synthesis of bilinogens like stercobilinogen and urobilinogen. See this figure again. After conjugation, liver excrete the conjugated bilirubin into the bile. Through the bile, it comes to the small intestine. From small intestine, it goes to the large intestine. In the large intestine, bacterial flora is present. These bacterial flora convert the conjugated bilirubin into stercobilinogen and urobilinogen. As there is obstruction to the flow of bile, conjugated bilirubin in case of obstructive jaundice does not reach the large intestine, and urobilinogen and stercobilinogens are not synthesized. Due to absence of stercobilinogen in the feces, the color of feces changes to clay colored stools, and urobilinogen is also absent in urine. It is again a clinical case. Patient of carcinoma of pancreas suddenly develops yellowish discoloration of skin and mucous membrane. What is your diagnosis? Comment on bilirubin level, comment on urinary findings, enumerate the other causes of above disease. These are the answers. Diagnosis is obstructive jaundice, or also called as post-hepatic jaundice. Bilirubin level, total bilirubin level is increased due to increase in conjugated bilirubin level in the blood. Urinary findings: patient excrete bilirubin in the urine detected by Fauchett's test. As the bilirubin present in the blood is conjugated type, which is water soluble, so it is excreted into the urine. So bilirubinuria is seen, and which is detected by Fauchett's test. In case of complete obstruction, urobilinogens are not formed and they are absent in urine. Other causes, just I have mentioned earlier, are you have to write down. These are some reasoning questions. Bile pigments are absent in urine in hemolytic jaundice. The reason is, in hemolytic jaundice, the main type of bilirubin increase is usually unconjugated type. Unconjugated bilirubin is insoluble in water, therefore it is not excreted into the urine. Next reasoning question is, bilinogens are absent in urine in obstructive jaundice. In obstructive jaundice, as just now we have studied, due to obstruction, bile does not enter into the intestine. As there is obstruction to the flow of bile, conjugated bilirubin does not reach the intestine, and bilinogens are not formed. As bilinogens are not formed, there is absence of urobilinogen in the urine. Next is unconjugated and conjugated bilirubin increases in hepatic jaundice. Just now I have told you, unconjugated bilirubin increases in hepatic jaundice due to defect in the conjugation due to hepatic damage, and conjugated bilirubin increases due to intrahepatic obstruction of biliary canaliculi. Kernicterus is seen in newborn infants when bilirubin level increases above 20 mg per deciliter. In Kernicterus, mainly the bilirubin is unconjugated bilirubin, and the blood-brain barrier of baby is immature, so that unconjugated bilirubin crosses the blood-brain barrier. As the unconjugated bilirubin is lipophilic, it easily diffuses into the tissues of brain, get deposited in the brain, leading to a condition called as kernicterus. So this is about jaundice. Thank you very much.